Hi, everyone. I'm Samira Daswani, the host of the podcast, The Patient from Hell. It is my utmost pleasure with which I have Dr. Ilana Yurkowicz as a guest on our show today. She is an incredibly impressive oncologist, doctor, and medical journalist. So I can promise you we're going to be going into all sorts of fun anecdotes today and getting a lot of insights from Dr. Yurkowicz. With that, welcome to our podcast.
Thank you, Samira. Thank you for inviting me. I'm really looking forward to our conversation today.
I want to jump right in because you've actually published so much content out there. And in preparing for this podcast, I was reading an article you wrote that's been published on the Times magazine. Can I maybe just go and pull out a snippet from it and then use that to open? Is that okay with you?
Yes, absolutely. In a Time magazine.
I'm sorry. This happens to me all the time. Ha! No pun intended there. So in that op-ed piece, I pulled a small snippet and I'm going to go straight into it. It says, doctors today spend 2 hours doing computer tasks for every 1 hour facing patients. Ordering something as simple as Tylenol requires doctors to click between 14 and 62 times, with the confusion causing errors in up to 30% of cases. Can you go straight into death by 1,000 clicks, which I think is a phrase you've used a couple of times? Can you explain that to us?
Sure. So this was an excerpt that was taken from my book, Fragmented. And in the Time op-ed, I am making an argument about why it takes forever to get a doctor's appointment, which is maybe something that you've experienced and all of your listeners have experienced. And I want to show what it looked like from the other side. So in 2009, paper charts were converted into electronic medical records with the incredible potential to connect patient data, large amounts of patient data seamlessly. And for the most part, paper charts were converted successfully into electronic medical records. However, it has not been all good. In fact, the way electronic medical records work today is that data is scattered throughout dozens of disparate electronic tabs, such that a patient's story, a patient's medical history is not written like a book. It is written like a book with pages ripped out, shuffled out of order. And the end result is that doctors and other healthcare providers are spending hours and hours digging through disorganized and repetitive patient charts, just trying to craft a coherent whole of a patient's story. And so that data that you cited was from a couple of papers. And honestly, when I was doing research for my book, it was stunning even to me as someone who lives this and is clicking through all of these tabs every day. So in one of the papers that I cited, it takes between 14 and 62 clicks to order a Tylenol, something that is a simple over-the-counter medication. And again, that paper showed that the confusion in the electronic medical charts caused errors in up to 30% of cases. So you can imagine the errors that are cascading from the electronic medical records when providers are just clicking and clicking, trying to find correct orders, trying to find correct data. And there are errors as well as near misses. And the end result, in addition to errors, is that providers are spending all of this time just clicking and clicking, trying to find the relevant parts of a patient's story.
Doc, can you talk a little bit about burnout? I know you referred to it in the book. Just as context for you, my master's thesis was on clinician burnout.
Oh, wow. Okay, so you're an expert on this.
I don't know about an expert. This was pre-pandemic. So, pre-pandemic burnout and today's burnout, I suspect, is looking a little bit differently. So a lot of the information I have is a bit dated. But the reason I say that is when we were looking at burnout, it's pervasive. Even pre-pandemic, we were looking at 1 in 2 clinicians are burnt out. Can you talk about burnout in the context of what we just spoke about?
Yes, absolutely. And so it's interesting you actually mentioned pre-pandemic and during pandemic or post-pandemic, because the data supports that. So it's about half of physicians say they are burnt out, about half, which is a really high number. And survey after survey shows that the number one source of physician burnout is bureaucratic tasks. And I want to emphasize that that has stayed true both before and during the COVID pandemic. And so, bureaucratic tasks, what are these? A lot of that has to do with the electronic medical records. And again, doing clerical and secretarial work and administrative work when physicians want to be taking care of patients, they want to be communicating with people, they want to be diagnosing and treating and healing people. And their time is just getting sucked up on these bureaucratic tasks.
Can we dive a little bit deeper into the life of a physician? The reason I say that is I think you wear a couple of hats, even from a clinician perspective, right? You're wearing the specialist oncology hat, and then you're wearing a primary care physician hat as well. So for a little bit, let's maybe stay with the oncology hat on. Can you describe for our audience, from an oncologist perspective, what your day looks like,
Yeah,
especially post patient visit?
with patient visits, he said, yes.
And then after, right? Because there's a patient visit and then there's all of this other stuff.
Yeah. Well, my day currently, I will share. So I do cancer survivorship visits. That is the bulk of what my clinical career is. So just a tiny bit of background on that. As you mentioned, I did train in hematology, oncology, and internal medicine. And then I opened a clinic that's primary care for cancer patients and cancer survivors. So I am doing bread and butter primary care with a special focus on the cancer piece and things that can happen after cancer and cancer treatment. And so, let's say a typical day for me is booked with patient visits from 8 a.m. to 5 p.m. And I actually consider myself very lucky that in my clinic I get 30 minutes for patient visit. In a lot of practices, doctors get less than that. They get 10 to 15 minutes per patient visit. But that day is stacked with the visits, meaning that is from 8 a.m. to 5 p.m. I'm seeing patients. And, that is the great joy of being an oncologist and being a doctor. I love seeing patients. What that means, though, is that all the extra work that I have to do for the electronic medical records, you have two choices. You're either doing it in front of the patient during the visit. So you're kind of looking back and forth, doing your best to establish rapport, make eye contact, but at the same time you're kind of typing and clicking, and your back might be turned to the patient. Or the more likely thing that I tend to do is take work home with me. I want to give the patient my full attention, and so I am making eye contact, especially if you're doing things like giving bad news. I mean, you have to be present in the exam room. And so at the end of the day, at 5 p.m., that's when I first start everything else. And so what is everything else? Everything else is opening up my in basket, which is the secure portal of the electronic charts. I start looking at messages that patients have sent me. I start looking at refill requests and signing those. I start looking at patient calls that came in throughout the day. I start looking at test results that have come in on all of my patients. And I'm messaging patients, and I'm engaging in that back and forth. Sometimes I squeeze that in. I do it during lunch, or I do it if I happen to have a few minutes between patients. But often the bulk of that is happening near the end of the day. And then the other thing I'm doing is charting. So everything that I communicated with patients during the day, during those visits, I am writing up, signing into a note. Um, if I'm very lucky, I can kind of squeeze that in during the visit. And I've worked so hard on efficiency. Every doctor will tell you that. And there's so many tips and tricks of trying to do this during the workday. But often I end up bringing about 3 to 4 hours of work home with me to satisfy all the other tasks of the electronic charts.
I am super glad you spoke about that, because I think one of the things that patients don't understand is the experience you just described. Right, from a patient perspective, and I've been in those shoes, and it's very difficult to understand the clinician's perspective when you're in that room.
Mm-hmm.
And it's just especially when you're going through the cancer diagnosis portion of it, it's traumatizing in a different way. So you're sitting with that sort of trauma in the room, in addition to kind of the clinical aspect of it. And it's very easy to forget what the clinician is going through sort of at the same time.
Well, you shouldn't have to. I mean, when you are dealing with a traumatic diagnosis and journey, I don't want you to be thinking about what I'm going through. I mean, that's really counterproductive of what the point of medicine is. It's about the patient. And so, I wrote in that Time op-ed, um, it was about a patient who I had to console when she didn't realize why I couldn't just quote unquote hop on the phone with her in the middle of a day to talk about a new symptom that she had. And so I shared with her, just like I shared with you, kind of what my day and what my practice looks like. That I had 1,300 patients who call me their primary doctor. I'm doing 3 to 4 hours of work every night after 5 p.m. That my days are stacked with these back-to-back visits. And I didn't tell her that to elicit sympathy, but very quickly it was like our roles had reversed. And all of a sudden she was being extremely sympathetic towards me, and she demanded to know who was doing this to me. And, again, I wasn't trying to get sympathy. The point of the visit was her. But, in this particular case, I was explaining to her just why I wish I could have called her when she had a new symptom, but the system makes it impossible to do so.
Can you actually, just going down that little anecdote, can we talk a little bit more about the consequences of the system being so fundamentally broken on a patient's experience?
Yes, of course. So I wrote this book called Fragmented, where I make the case that the system is broken in a very specific way. I write in the intro of the book that it's actually become a cliche at this point to say that healthcare is broken. But the reality is a lot deeper as well as more specific than that cliche lets on. And I make the case that it is fragmented. And what I mean by that is that doctors and other healthcare workers are constantly working in a state of being partially blindfolded to the full details of their patients' medical stories. And then, on the patient perspective, patients and family members and other loved ones are burdened with bearing the full responsibility of repeating their medical traumas to dozens of new faces and keeping the pieces of their medical histories together when, as we alluded to earlier, you should be focused on other things. You should be focused on sickness and healing. That is the role that a patient should be playing. And so in the book, I divide it into 3 parts where I capture my 3 arguments of how the system is fragmented. And I'll go through those very briefly. The first part is about data and how data is fragmented. So everything we just talked about, how the electronic medical records scatter data so that it's not written like a narrative, as well as how the electronic medical records are not always shared between different facilities, so that physicians are often still using fax machines to get details of their patient stories when they happen to be done, even sometimes a block away in a different hospital. So that's part one, is how a patient's story is just not written like a book. The data is scattered everywhere. Part two, I called loss to follow up. And it has to do with the relationship between a doctor and a patient, which is so fundamental to what good medicine is. And I say in the book that, very rarely medicine is one and done, where you just see a patient, you do one visit or one consultation, and you move on. The crux of good medicine is follow up, meaning a doctor has to see her patients, and a patient needs to be able to access their doctor. And I catalog in that section the ways that our system fragments that relationship. And part of it is third parties, it's insurance barriers that deprioritize follow up, actually in lieu of new patient visits. And part of it is the very mundane but important aspect of scheduling. And we can talk about this later, but how we structure from the inside physician schedules so that that follow up is actually not prioritized. And then finally, the third section of the book is about medical culture and mindsets. And so while the first 2 sections lay out these external barriers of fragmentation, the third section is about some of those internal mindsets that still teach and train doctors to look at a slice of a patient's story rather than the big picture. And part of that, for example, is our emphasis on specialization and subspecialization, where you can have multiple different physicians all looking at one piece, like the heart or the kidneys, or just the cancer, perhaps, and not everything else. And everyone can be perfectly managing their slice, but the whole can still fall apart. And I believe these three factors, data, follow-up, and mindsets, all converge to create this really, really deeply fragmented state.
Thank you for that overview. I think it's actually really profound. Can we use that as a way to enter cancer survivorship?
Yes, definitely.
So with that sort of setup, right, there are the three pillars that you laid out. At least from my perspective, from a very personal lens, I think all three in the survivorship realm, and just to be super clear about what I mean by survivorship, I'm talking generally speaking the period post active acute treatment. I know there are different definitions out there, but that's how I interpret it.
Yeah.
Um, it is truly like the burden and the responsibility in the patient for me skyrocketed.
Yeah.
When that transition happened, it just skyrocketed because all of a sudden you're at the edge of the cliff and you fall off. And you're like, huh, okay, all right, interesting. I don't have a PCP.
Mm-hmm.
If I do find a PCP, they have no idea about my oncology history, nor do they know honestly how to manage me.
Mm-hmm.
My oncologist is super, super busy. I know the oncologist cares about me deeply, but in the stack rank of patients, I am not the problem child anymore. I am very far away from the problem child and therefore get deprioritized all the time. And to some extent, rightfully so, compared to the relative positioning of, problems in that patient population. But then what happens is you kind of are left with this mess, and navigating that is honestly, even today, it's still really, really difficult. So I'd love for you to talk about that from your perspective.
I'm so sorry that happened to you. And that story, a version of that story that you just told, is one that I hear, 6 to 8 times a day. That is kind of the current reality of what cancer survivors are burdened with doing. They are responsible for navigating their care after cancer. And, I'll talk about what I did to try to help some of those burdens. And so yes, when I was on the oncology side, when I was a fellow, I saw this a version of that story over and over, where I was the one responsible for getting someone through chemotherapy or active treatment, and then very often amazing things happened, and patients were cured of their disease, or they were put into remission from their disease. And then we said to them, well, you don't really need to come back and see us as frequently. You can go see your primary care physician. And then a couple things happened. Patients either didn't have a primary care physician, or they had a primary care physician who they lost touch with throughout the whole process of falling into cancer world, where their oncologist functioned as the de facto primary care physician, or they found a primary care physician who just didn't have the background or training, or expertise or time to be able to sort through the cancer history. And so when I was thinking about what to do after fellowship with my own career, I I just knew that I had to position myself in some way to help catch some of these gaps, where sometimes a patient would go to their primary care physician, and the primary care physician would still send them back to their oncologist and vice versa. And the other thing I would add is that after cancer treatment, even if the cancer is in remission or cured, a whole host of new issues can crop up, as I'm sure you know very well. There are long-term and late effects from treatment. So just for example, people might be dealing with neuropathy. They might have higher risk of secondary cancers after treatment. Um, and then there's the whole emotional and recovery phase of this, where patients are often very surprised that the hardest part of a cancer journey can often actually be after their cancer is in remission. Because before that, it's like the entirety of your focus and your life is focused on survival. And then trying to make your way back into what resembles a normal life for you and figuring out what that looks like is an enormous emotional and psychological transition that many people very, rightly struggle with. And so cancer survivorship kind of manages all of that. I manage the physical side of it as well as this whole, kind of being a support through that emotional navigation as well. And so what I decided to do at the end of all of my training, which was 4 years of medical school, 3 years of residency in internal medicine, 3 years of fellowship in oncology and hematology. It was the radical thing to go back to primary care and to open a primary care practice for cancer patients and cancer survivors, where the goal was that I would be catching that gap, where if patients felt like they couldn't find a primary care doctor who understood their cancer history, I wanted to do all of that in one place. Like I wanted to be the primary, the doctor that focused on the whole patient, um, with an understanding, with a nuanced understanding of what they had gone through and what may lie ahead.
Doc, thank you so much for that overview. One, can I just tell you how grateful I am that you made that decision?
Thank you. I am too. It's been such a privilege.
I can tell you from the patient perspective, this is partly why I think sometimes people, it's one of the reasons why the podcast is called The Patient from Hell, but I actually went into a search mode where for about 4 months, this sounds horrible, but I actually met a lot of PCPs.
Mm-hmm. Mm-hmm.
Because I was essentially screening, right? I was like, I need a PCP who understands oncology, who understands me, who is willing to take out the time to meet me and not just do the sort of like standard playbook of treating a 30, 32-year-old, otherwise healthy patient,
Mm-hmm.
but is helping me manage all of the many aspects of survivorship you mentioned.
Mm-hmm.
And I met about 6 PCPs across 3 systems. I'm not even joking.
I'm wondering actually how long that took you. Like, was this a year-long process or
It
longer?
was about 6 months. It was
Yeah.
about 6 months. And this was because I was still kind of in the system as kind of in active treatment. So I had started that search, actually thanks to my oncologist who told me, who gave me a heads up being like, hey, look, like in about 3 months, you're going to be done. You need a PCP on file. I need someone to like take over. So please start finding a PCP. So like they had given me, like, so this was during me being a flagged patient, right? So like,
Yeah.
it let me get through a little bit of the wait time of getting an appointment. And yeah, I actually said no to all of them.
Yeah. Did you ever end up finding a PCP?
I did. And then 6 months later, this individual switched from clinical medicine full time to research. So it's just, it's
So hard.
goodness.
It's so hard. And, we were talking earlier about it. It's not your job to envision what it's like from the doctor's side. I would say rather it shouldn't be your biggest priority to envision that. But from the standard, primary care physician side, time is a really big factor here, right? So if you're trying to do, if you are being pushed by administrators into doing 10 to 15-minute visits,
Mhm.
and you get someone like you that has a cancer history that you need to first maybe get outside medical records, read those, try to understand it, sit with you then and talk about what your experience has been like and what are your most pressing issues, as well as try to address all your preventative health in 10 minutes. I mean, that sounds like a joke, right? And so the system is not set up for primary care physicians to be able to do cancer survivorship. And I will share in my practice, I'm very fortunate for new cancer survivors. I get an hour with them. And that is not something that most primary care doctors get. It's something that, we had to champion because it's such an important part of providing primary care after cancer.
I really appreciate it. And I do my knowledge, and you can correct me here, there are actually not that many primary care physicians who specialize in the way you do.
No. To my knowledge, and maybe your listeners will correct me if I'm incorrect, I think I'm the only board certified medical oncologist and hematologist that's doing primary care for cancer survivors. There are a few though, and I think it's wonderful that this is happening, and it's a trend that needs to continue. Primary care physicians, people who are trained, in primary care, then carving out this focus on cancer survivors, and I think that is the way we need to go. Um, when I opened my practice, I saw it as, I didn't think I was doing anything that radical because there was precedent for this with other patient populations. And the example that I had in my mind was geriatrics. As a geriatrician, it is a primary care doctor for patients older than 65. And I was like, I want to be a primary care doctor for patients with a history of cancer. So it's just carving out that that specific patient population within primary care. I think it's very doable. And I'm hoping more people, people will listen to your podcast and maybe be inspired to either pursue that route or encourage someone they know in medicine to pursue that route.
Your goal and my goals are the same. I fully agree.
We're so blind.
No selfish reason at all.
Well, you just know how huge the need is.
Yeah. Mm-hmm. It's very true. And the time limitation, I think, is not just in primary care, right? I was reading a paper recently, and the average time with an oncologist is 23 minutes?
Something like that. Yeah.
Like, the world we live in is, that's just, to me, it is so fundamentally wrong. And we get stories all the time, right? Patients reach out to us, and I heard a story recently from someone who's going through it, who started treatment and has not met the oncologist.
Yeah. It's getting worse. And that's why I wrote that op-ed in Time. And, a lot of why I wrote my book. Access is decreasing for so many reasons. And in the Time op-ed, I just lay out three. One is the tech. If your doctor's time is just being sucked up on sorting through EMRs, they're not seeing as many, they're not spending the time face to face with you. Number two is team support, right? So we do need better delegation of bureaucratic tasks within medicine. And we kind of just need armies of RN support and APP support and social work support all sitting within the same place, and MA support, so that, doctors aren't the ones on hold for an hour trying to do a prior auth, to get your chemotherapy approved. So they can spend that time talking to you about it. And then three, which I think is just, again, such a huge issue here, is time. And why do doctors get such low amounts of time with patients? It's the payment model. It is still primarily in this country a fee-for-service payment model, where doctors and healthcare organizations are reimbursed on a service. Now, what is a service? It can be a round of chemotherapy, a joint injection, or in primary care, a service is an office visit, that face-to-face, meaning nothing else counts as paid work. None of the time that you spend outside the room putting the pieces together of a patient's story counts as paid work. So what happens? The financial incentives are stacked so that you're doing face-to-face visits all day. And then, the average primary care doctor's panel swells to over 2,000 patients. And it is the same for it's not quite that extreme for specialists, but the financial incentives are stacked to see new patients over patients following up. And that is why, if you're competing against literally thousands of other patients, sometimes for an appointment, you're not going to be able to see your doctor.
Usually we don't go into problem solving mode, but I really could not help myself, because I think you do such a good job of painting the picture of the problem, that I really would like us to talk a little bit about the solution, but not so much an ideal solution, but more kind of a near-term solution, specifically with the lens of a patient. And the reason I say that is, I'm going to jump the gun a little bit.
Sure.
I want healthcare to change. I've worked in healthcare my entire career. I truly, desperately want the fundamental root causes to shift. I also don't believe that's going to happen in the near term. I think in the near term, I'm just going to define that 2 to 5 years, I think we'll see some shifts, but shifts in healthcare are just slow. They are just slow. They're not going to happen overnight. It needs the kind of change that we need, requires kind of a reconfiguration of the full system.
Yes.
And as much as I want to hope and believe, I don't think that's going to change anybody else.
So I'm actually so glad you said that, because I agree with you 100%. I do lay out in my book long-term solutions, because I agree with you. I want to get to the root cause. I think how we structure healthcare, it needs to be fundamentally redesigned. But at the same time, I do think there are things that people can do right now. And I include all of that in the book too, because it's important to navigate the system as it stands. Yes. I think we have to do both in parallel. We can lay out blueprints for 10, 20, 30 years from now, But right now, you're seeing your doctor, I'm seeing patients, and we all need to navigate the system better. And so one of the things I do in the book is I give a checklist at the end of the patient's narrative, the full medical story. And I say very clearly that in our fragmented system of medical record keeping, you, the patient, are the only guaranteed source of continuity in your own care. Do I think it should be this way? No. But right now, that is how it stands. And so I created a checklist to empower people to be the shepherd of their medical story and to be the keeper of their medical story. And I tell patients, will that involve repeating things over and over to new faces? Yes. But it is in your best interest to know as much of your medical history as any of your doctors would know, to have all of that somewhere stored in your possession, and to bring that over and over and over again to your new doctors. Don't rely on the back end, meaning if you see a new doctor, don't just assume they're going to have access from another facility. Even if they say they have access, honestly, I would empower you to bring it. Either it's often on your electronic device now, where you can pull up patient portals with all of your previous data. But it also helps to have like an elevator pitch, like a shorter version of your medical story that you know well and that you have honed and that you will bring to every new provider that you see.
You see me smiling because you see me smiling only because I think you're fully and 200% right. And it's a burden.
Sorry. Yeah.
No, it's exactly right. It's a burden, and I definitely don't think I don't have as elegant of a summary as you described it right now. But we say the same thing to patients all the time. We say it all the time, and the number of times I personally have been in the same system, the same EMR, back-to-back visits, day by day, like literally I'm in the system every single day. And every single day, I say the same medicine reconciliation and it does not get updated. And I show up 1 year later and it's still not updated.
Yes.
And this is the same system. This is not even like us transitioning systems. It's not putting data anywhere. That's just the reality of, to your point, the back end that we're working with, despite the phenomenally intended clinician teams we have, right? So despite all of that, that's just the reality of the data. So I really appreciate you summarizing it in quite that way. I'm going to ask for one more follow-up to that, which is, in addition to being the sole point of truth effectively of your medical history, right? You the patient, are the only source of truth that exists, essentially, in the system. I think there's the data you as a patient need to have under your control, and then there's communicating that with the clinician. And I'd love for you to talk a little bit more about the communication part, because I heard you say the elevator pitch, which makes tons of sense. I'm going to push back just a little bit on that, because I'd love to understand how to do that as a patient. Because in an appointment, my understanding is appointments are structured. It's not lose 10 minutes. It's not lose 15 minutes. There is a structure at place. And I've tried this. Just the only reason I can say this is I have very intentionally tried breaking the structure because I realized that it wasn't actually serving my needs. It wasn't giving me the time to ask my questions. It wasn't giving me the time to actually report my symptoms. It wasn't giving me the time to get to the goal that I had for that appointment.
Yeah.
So I'd love for you to talk a little bit more about, let's assume patients have their medical summary in the pitch. How should they communicate that?
Well, what you said was already so important, and you're already 3 steps ahead because you're coming into an appointment with an agenda. And that's really important. It's one thing to have your story and to communicate your story, but often you're there for a reason, right? Like you have an agenda. There are certain things that you want to address. Now, at the same time, your physician or your provider, whoever you're seeing, has their own agenda. And what I would suggest is at the beginning of the visit, just breaking the fourth wall and laying that out there to make sure that both of your agendas are going to be addressed. So, I open visits by asking patients that question directly. I know many providers don't, like, what are you hoping to get out of the visit today? And I take notes right at the beginning of like 1, 2, 3 questions they want to address. And, I will be upfront. If that list ends up being 12 things, we will have to break it down. We will address 1, 2, and 3 today because every one of those things takes time and deserves time. And then we have an agenda and we know how to go through the visit. And so if your provider doesn't ask you that, still be upfront about it and say that your hope for this visit is I have 3 new symptoms that I would love to address today. Or my hope for this visit is I want to get caught up on a plan for preventative health because I haven't seen a primary care doctor in a while. Whatever it is. But knowing what that is before you come into the visit and communicating that clearly. So often this doesn't happen. So then you are just kind of thrust onto the conveyor belt of whatever the provider's agenda is or whatever just the system's agenda is. And so knowing what that is and laying it out just like you do. What do you think? I mean, I'll ask you, what do you think when you've tried to do this? What is the pushback you've been given from your providers?
It's a good question. So actually, it's the foundation for the entire all of the work we do is what we're talking about right now. So what happened was, I'm gonna, if you're okay with it, go down a little bit of a tangent and come back to the question.
Yeah,
we're asking is, in my prior life, I'd helped build a PRO tool, patient report outcomes tool for oncology, that's used at a different large system, not in the one that I was getting treated at. And here I was, I knew the data, I knew the importance of symptom tracking, monitoring everything, especially during chemotherapy, and didn't have access to a tool that I had helped build, which is, classic healthcare. Such a good moment, right? And then found myself in these appointments that are 20-ish minutes where we're making what felt like irreversible decisions. And it's not always irreversible, but it really does feel like it's an irreversible decision. Mm-hmm. And I found myself, despite being prepared kind of on the data side of my health, I found myself unable to communicate both the goal and then the question. Because oftentimes patients ask, what is your goal? Macro goal is easy, right? I want to be disease-free. Like that's very easy. The micro goals are really hard. Mm-hmm. It's, what do I want from this treatment? What do I want this week? What do I want next week? What do I want 3 months from now? It's very, very difficult, at least for me, to get to that point. So I found myself struggling with both those things. So I ended up designing a paper product just for myself. And the paper product, it was truly just for me. I pulled self-management templates that's available, and in the data, I did the research and put it together in a old school paper-based planner. And the one thing that I remember iterating on a couple of times was how to communicate my questions, my goal, and my symptoms to the oncologist. Mm-hmm. And what happened was, pre-planner and post-planner, my appointments actually look very different. Mm-hmm. Pre-planner, it really was whatever the structure is, that the default structure. Post-planner, and I really give my oncologist a lot of credit for this, is she really truly embraced me bringing that tool in. And what happened is the appointments just shifted. Yeah. It shifted to my goal, my agenda. It wasn't that the oncologist's agenda wasn't met. It was just that we started with mine, which did two things. One, it gave me a sense of calm and control because it allowed me to be almost take a breath, being like, okay, my questions will get answered today. Mm-hmm. That kind of settling emotionally did happen. But also what I found was our appointments actually got more efficient. Mm-hmm. Mm-hmm. Because we sort of we got rid of the sort of complicated things up front, the things that I was stuck up on up front. And then everything else kind of just kept rolling. And we also started carving out decision meetings from non-decision meetings. So that was the other thing, where if a decision is being made, by the time we go 6 months in, she knew that I was not making a decision the first time we met.
Yeah. Yeah.
So we'd have a data discussion and then come back for a discussion meeting, a decision meeting. So it was also the type of appointment started shifting. Yeah. Even though from a billing perspective, it's a visit is a visit. What was happening in the room was actually very different. So sorry, long answer to your question, but
I love that.
It makes of it for me.
Yeah, I mean, I love that answer. And I think the realization that you came to with the pre-planner and the post-planner is it's a journey that I've seen many of my patients come to, whether they've come to it on their own or I've just been very explicit with advising it. that you come into the appointment with your agenda and your questions. And it takes a while of navigating the healthcare system to understand that you need to do that or you should do that. I think what you touched on too with the decision visits and the non-decision visits is very, very astute. And I sort of do the same thing in my own practice. When a big decision needs to be made, I totally hear what you're saying. Like it can feel immutable. And then somehow within 5 minutes or 10 minutes, um, sometimes based on a small part of your life or history, like maybe all the details aren't even being laid out. Like you guys just made a decision now that will affect the rest of your life, that might affect your life, like whether you survive or not. And it happens in 5 minutes without all the data. And that is a terrifying reality. And we do need separate time to do these things. We need time to make decisions, which is separate from time to manage symptoms and side effects and deal with other things, other concerns, and preventative health. So what you are describing is kind of what my North Star is, for the healthcare system as a whole. That is what I try to do within my own practice. But we are limited by so many external barriers, many of which we have talked about in this podcast. And a main one here is the time again. We are limited by 10 to 15-minute appointments. How can you make these life-altering decisions within 10 to 15 minutes, much less address everything else? Well, the solution right now is to carve it up into different visits because you're not going to get an hour visit in almost any place except when you're a new patient in my practice. But almost every other place, you're not going to get an hour. And so you carve it up into different visits. Well, that leads to issue number 2. The wait list for that next visit might be 6 months because of everything we also talked about, that you're competing against hundreds or thousands of other patients for those visits. And so without true access, which means an ongoing, relationship, an ongoing conversation, what you're going to get is these fragmented conversations, and big mistakes can be made completely unintentionally because you're just very quickly trying to fix something. We jump to quick fixes because we don't have a system in place that allows that sort of seamless, ongoing interaction. Now, that's a very negative outlook I just gave you. I think the flip side of this is by talking about it, and I've written so much about this. There are models in place that do it differently. They tend to be the outliers rather than the mainstream, but they exist. And it sounds like your relationship with your oncologist is one of them. My intention is that my practice with my patients is another one, and that these models will spread once we just even get to that base recognition that it takes time and multiple visits sometimes to make these critical life decisions.
No, I really appreciate you saying that. And for what it's worth, I don't see it as a negative outlook. I just see it as a real thing that we're grappling with, right? It's the reality of the world we live in, and no matter how disheartening it can be, at least my goal has always been to enable the patient to know that.
Yeah.
Because very often patients don't know that.
Yeah.
Right? They don't know that they can change the appointment structure.
Yeah.
They don't know that they can request a meeting to be broken up into 2 visits, right? Like, yes, it's an appointment scheduling issue, but in the oncology world, at least acute treatment oncology, all the clinicians will get really mad at me for saying this, as will the system. I apologize, but from a patient perspective, once you make a decision, the visit has not closed, so you will get priority to get that appointment in because the decision meeting is really important. You can't get to the next step of care without that. Only, carved out oncology specifically, right?
Sure.
But the reason I say that is I think there are more voices needed like yours that are constantly talking about it, because otherwise there's no pressure on the system to change.
Yes. Oh, yes, of course. I spend a good chunk of my visits, I will say, with my patients doing medical stuff, and then a good chunk of my visits talking about how to navigate the system, which is actually pretty wild when you think about it, because I've just spent so much time talking about how we don't have any time. and we don't have time to even make all the medical decisions or get through the medical story in a visit. But it is such an important part of your health. I mean, that's why I wrote this book too, right? I mean, I wrote this book so that people basically have in one place at home everything that I tell people during a visit, or multiple visits, which is how to be the agent in your own medical story. Part of that is recognizing that you are the agent in your own medical story. You are that full source of continuity. You cannot assume that your providers have all of your information or that they don't have it in a garbled way. They don't have it in a meaningful way. And then you are also the agent in making decisions about next steps that affect your health and your body. Your providers are invested in your health, but nobody is more invested than you, and nobody knows you the best. I mean, that sounds very obvious, but there's way more to you than your medical data and your life priorities is, what you want to get out of life, what makes a meaningful life to you. And that needs to come into your discussions with your physicians.
That is such a beautiful place to wrap up, because I think you truly, truly, very elegantly summarized a lot of the work we do, and honestly why this podcast is called The Patient from Hell. Because unfortunately it does have consequences. Like, I think by doing everything you just said in the wrong system, it can have consequences, but that doesn't mean you shouldn't be doing it.
Yeah, the last thing I'll say about that is I love the title of your podcast. Try to find physicians and providers who will not punish you for advocating for yourself. There are many out there, trust me. I wish it were the default. I think the system makes it hard to be the default. But they exist, and it is a free market. You can doctor shop in most cases where it's not a medical emergency. And try to find somebody that you click with who will empower you to advocate for yourself.
Thank you so much. Thank you for saying that. Thank you for being on this podcast. Thank you for all the work you do. And I hope that as you grow in your career, we can stay in touch with you and support you in any way we can. So
that sounds great. Thank you for all the work that you do. I really enjoyed this conversation.
Thank you.
Take care.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.